Good afternoon. So we are now on the final session of the open house for H2O. It's what I hope to be a very interesting session for you on the core outcome set definition for two oncology indications. And we will hear basically in the two presentations from the work that has been done, reporting on the work that has been done, and the conclusion on defining the core outcome set for breast metastatic cancer and lung cancer. I'm here in this session with a group of very distinguished panelists that will actually follow the presentation with the panel for a panel discussion. We have Helen Edayati, Associate Professor, Senior Consultant, Clinical Oncology in Karolinska. Matthias Preußler, Professor of Medical Oncology, Head of Clinical Division of Oncology, University of Vienna. Belle de Rooij, postdoctoral research at Netherlands Comprehensive Cancer Organization, and Kelly de Ligt, postdoctoral fellow and project lead at Netherlands Cancer Institute. I am Francesco Padalano. I'm in Novartis, and I'm actually I'm leading the patient-reported outcome Center of Excellence in Novartis, and I'm also leading a work package in H2O. I would like to start introducing and give the podium to Miriam Felting, that is Senior Advocate and Program Manager Quality of Life at the Dutch Breast Cancer Association. I do know, Miriam, that you have to leave at 4:30 sharp, so without any more introduction, give to you the opportunity to frame what is basically the needs for patients in these challenging indications.
Yes, thank you. I will share my screen and hope everybody can see it. Thanks for the opportunity to contribute on patient perspective, an important part. Not used to present all the time in my English, so already excuses for sometimes not finding the right words. You already introduced me, so I will start. I start with, hopefully it will start. Oh yeah, sorry. Oh, sorry, it was a little bit too fast. Yeah. I will start with a quote of one of my patient advocates with metastatic breast cancer. We talked about her appointments with her oncologist, and every month, 3 months, she has a checkup, and they look at the blood values, and they make a follow-up plan, and she's really happy with the oncologist. But when we talked about it, she said, "I'm not often really asked how am I doing," and I think that's where the outcome sets can help to have these conversations, but the patients so needed this conversation. And for metastatic breast cancer, there were no outcome sets or pros yet, nationally and internationally. So as a patient organization, we're really glad that's finally here and that we can contribute to this. And we cannot wait that is accessible in all patients, for all patients in all hospitals in the Netherlands, but also European. Internationally, there's also a charter with 10 goals for better metastatic breast cancer. We are working on with a lot of patient organizations in whole Europe and whole world. And this 4 goals with the arrows, patients in the Netherlands selected as most important, where we are working on with the breast cancer organization for this year. And this big project, the H2O project, really is contributing to all of these 4 collecting data.
You may need to scroll to go to the next slide.
Oh, yes. Are you not seeing these MBC goals?
No.
Still not seeing it?
We may trying to go to the
Miriam?
yeah, a different view with a different view with the
let us try to share the screen.
Yes.
So
yes.
which slide should we share? This
yes.
one? Okay.
Yes. So so this is the global charter I was talking about, and the four arrows the patients in Holland selected to work on as a patient organization. And this project is contributing to all of them, collecting data, improving quality of life. All patients receive best treatment and care, and improving communication between patients and healthcare provider. The next slide, please. Oh, next one, yes, this one. And why we think from a patient perspective, outcome sets are important. They can contribute to appropriate care, focused on the patient, a term really often used in Holland on the moment, but it's so important that the care fits the patients. And outcome sets and pros are more focused on health and well-being, and not just only on the disease. And I think that's really important, also with a lot of attention to positive health care. It's contribute to better quality of life, disease management, monitoring of side effects, but also insights in personal concerns, and also the big data. I think it's really important that we are going to have all the big data nationally and internationally so that you can compare, to give some insights. And I think really, because all the treatments is more and more personally, it's more important to collect big data from big groups for the patients, and also having better communication and conversations together with the healthcare providers and the patients. Also, when you have big data, you have patients like me data. Shared decision is also more easy to have that conversation on choices on treatment. Next one, please. Importance of things we know from patients about outcomes. Really use the outcomes consequently. If they see that data is really used, and the questionnaires are really used, patients are willing to complete questionnaires from time to time. And I think really metastatic breast cancer patients are really willing to fill in if they see that it's really used, and people coming back on it, on the topics. And also, I was reading in a research that questions, till 50 questions, most of them really want to fill it in. Not all the patients are the same, so you have different groups. And I think there are also patients who are low literacy of elderly patients, maybe. So I think you have to really talk about it with the patients if they fill in, or to look at other things. Give patients themselves insight into their own data, easy accessible. It provides insight in the course of the disease, seeing patterns. Sometimes they're not aware of some factors. I thought it's going well, but now I see that it's not going so well, and I never was aware of it. And that's important. And I think topics that may not be easy to discuss are now more visible and easier to discuss, like sexuality, relationships, because it's there. So sometimes the conversation is done more easily. But also allow patients to indicate themselves with topics they want to discuss. Ask that. So not only the things you see, you think, oh yes, I'll discuss about it, but also ask the patients, are there topics you want to discuss, or you want to talk about it with me? And I think, that's are the most things, and I think really it provides insights. The patient will be heard and we will be seen. And that's, from patient perspective, so important. Next slide, please. Lessons we learned in other projects on PROS, on outcome projects we are participating in as patient organizations. It's really important that it's supported, that the sets are supported, and I think now it's really there on this project. Making use of the knowledge and possibilities that are already available and there. We also see that early involvement of the healthcare providers really going to use it. It's really important that they're really early involved and that they can also think with each other how to use it. Invest really in that implementation, especially how to read outcomes sets, so how you can read them, but also how to conduct conversation with these outcomes, because it's sometimes really different the way they work before than working with PROS and outcomes in the with the patients. But also allow flexibility on the hospitals, how they already work. So I think that's also really important, that there's a little bit of flexibility in implementation. You have to do how it works, but if there's some flexibility, they're more able to work on it and also implement it. Really look forward that it's widely available for all patients with metastatic breast cancer, also literate people, elderly people. I think we're proud to contribute to the sets. Our involvement at early stage was really nice as part of the project group. And it's really important, that's what I want to say, to involve patient organizations on time, make them a partner, keep them informed. This also makes us feel involved in propagating it. Also later on, it helps us to point out the patient's importance also on completing forms, so we can also stimulate patients, really fill it in. It helps to collect big data, but also for your own quality of life. And I think as a patient organization, together with the whole project group, we really made some difference in the sets, like the question on the relation of the healthcare professional and the patients. We really make heart of it, and it's in the set now. But projects like this also takes a lot of time, sometimes getting stuck in making all technical possibilities. And despite of the fact that there's often still a lot of to do in this project, everyone and all, that's what I want to say to healthcare professionals, everybody can already start with a good conversation with the patient to ask them how it's really going with your patients. So I will stop with that.
Thank you, Miriam. I know that you have to leave, so thanks for taking the time to give us that important message. And if you don't mind, I will use some of this message in the panel discussion later on.
Yes, please.
And as a part of the discussion points that we want to pose, and as well in the concluding remark, because these are really important points that you made. And thanks. So you're welcome to say, but I do know that it would be great to have you on the panel discussion.
Yes, sorry. Next time.
Next time there will be
a good panel discussion.
Right, and with this, what we want to do is to move to the definition of the two core outcome set with Belle and Kelly that will present the work done on the metastatic breast cancer and lung cancer. I think Belle, you starting. Kelly, who is first?
Yeah, I guess I'm first. Yeah,
okay.
I'm going to share the screen now. But I just have to check how this works, because I have, as you can see, my background is not working and everything else is not working as well. So this is a bit difficult. Maybe the organization could share slides, because I think it's not working actually. Or is it?
I think it's working, yes.
Yeah, it's working?
Yes.
Not sure though. Yeah, here we go. Okay. Thank you for the opportunity to present about the core outcome set for metastasized breast cancer. On this slide, you can see all the collaborators in this project. Since we only have 7 minutes, I'm going to discuss briefly the relevance, goal, and method of this study. And then I will just show you the core outcome set with the outcomes that we have included in this set. So first, a bit about the relevance. Miriam already told a bit about this. There is already a core outcome set for early stage breast cancer, which was developed by the ICHOM, the International Consortium for Health Outcomes Measurement. But metastatic breast cancer is notably different, which is that patients won't get better anymore. So treatment is focused on extending survival and controlling disease progression. And well, this is all while maintaining a health-related quality of life, which is important because treatment causes symptoms, and cancer, the breast cancer itself causes symptom of disease burden as well. So symptoms and disease burden we call adverse events, and these should be followed up systematically and monitored regularly over time, which is recommended by the Advanced Breast Cancer Association in their guidelines, but this is currently not done yet. So our goal was to develop a core outcome set for patients with metastasized breast cancer, and core outcome sets are important, just as Miriam already told a bit about, because we want to collect data homogeneously in clinical trials, which will lead to better interpretation of results and therefore better research-informed patient and policy decisions. But also if you implement a core outcome set in clinical practice, then you can change clinical encounters for metastatic breast cancer patients by improving symptom management and improving patient-provider communication. So to develop our core outcome set, we have used a mixed method approach. And we started off with a literature review in which we identified existing relevant outcomes. We came up with a list, and this list was reviewed by our expert group in 6 separate meetings addressing all types of outcomes. From this, we had a second version of this outcomes list, which we used as input for our modified Delphi method. I will tell about this on the next slide. But what is important to know that after the Delphi, we had a third version of the list, and we discussed this third version in our final consensus meeting, which finally led to our final core outcome set for metastasized breast cancer. So a little bit about the Delphi study. A Delphi study is actually a questionnaire that is completed anonymously by a variety of participants, and people score the relevance of items, in our case, outcomes, on a 9-point Likert scale, in which 1 means that an outcome was not so important, and 9 means that an outcome was critical to include in the core outcome set. Participants could also include comments for each item, or suggest new items, or select unable to score if they felt that they did not know enough about this item or outcome to score relevance of this. Our Delphi consisted of 2 rounds, and outcomes that were scored relevant by 70% of participants in the first round were transferred to the second round, and in the second round, again, for 70%, these were transferred to the final core, the final consensus meeting. So just briefly, some results. We started with 125 outcomes from our literature study, which was based on 2 separate literature studies that were conducted at the same time as our study by Clarijs et al. and Bedding et al. Then our expert group looked at these 125 outcomes, and our expert group consisted of a multidisciplinary panel of healthcare professionals and patient advocates, including Miriam. So then this second version of the outcomes list was discussed by the Delphi participants. And as you can see, there were quite a lot of participants, but the majority were patients and patient advocates and healthcare professionals and researchers. And we had 4 categories of outcomes, namely variables for data normalization and several outcomes, including survival, adverse events, and health-related quality of life. And as Miriam already said, we think that the patient perspective is the most important, and also the effect of breast cancer and breast cancer treatment on the patient is the most important in this project. So therefore, we have included quite some adverse event and health-related quality of life outcomes, but I will show you in a bit. So here you can see that for each step, well, you can see the outcomes here, and then you can see each step happening and the percentage of participants who considered this outcome to be relevant. And then in the end, you can see that some outcomes were included and some were not. So now I just will show you the core outcome set. We start with the adverse events, and I will just give you a minute to look. And then we move on to the health-related quality of life items. And as you can see, these both are quite a number. I will go deeper into that in a minute. So we also included some survival outcomes, but for the sake of time, I will briefly discuss this. And we also included patient characteristics and other diagnostic and treatment factors that are important to understand the data and interpret the data better. So as I said, there were quite a lot of patient-reported outcomes, including adverse events and health-related quality of life. And here you can see that, well, those are the items that we monitor quite regularly, and the other items we want to include less regularly. So we hope to reduce the registration burden because of this, hopefully a little bit. I think it's time for Bella now to share the screen. So I stop sharing. I hope it's working.
Yes, thank you so much, Kelly, for this really nice overview. And yeah, it's a pleasure to also present the core outcome set for lung cancer, which is a really similar approach to what Kelly has already really nicely presented. I will be be brief to make sure that we have time for the panel discussion at the end. Is next slide working? Yes. So for lung cancer, there has already been developed an ICHOM lung cancer outcome set in 2016. However, since 2016, there have been some significant advances in the treatments of lung cancer, and immunotherapy and targeted treatments became standard of care for non-small cell lung cancer in the past couple of years. So as you can see here in the figure, the ICHOM sets included mainly patient-reported outcomes that were a bit more generic and mostly related to the more traditional treatments like surgery, chemotherapy, and radiotherapy. So for H2O, we really aimed to develop an updated outcome set that really captures the patient perspective and also captures the impact of these novel cancer treatments for lung cancer. We used a really similar methodology as Kelly has already nicely described. So literature review, expert group meetings, and a Delphi study with a couple of voting rounds in which participants in 4 stakeholder groups could indicate how important they thought it was to include a specific outcome. And then after the Delphi voting rounds, we concluded with 2 consensus meetings to define the final core outcome set. In this slide, I want to show you the numbers of participants and the different stakeholder groups. So the expert group that was involved in the development of the preliminary set prior to the Delphi survey and was also involved in the consensus meetings to define the final core outcome set. This group consists of 17 members, a really nice mixed international group of stakeholders. And for the Delphi study, we had 146 participants coming from 12 different countries, actually. So we're really proud on the outreach in this study. For the consensus meeting after the Delphi study, we discussed the results of the Delphi study. And prior to the Delphi study, we defined a threshold of 70%, meaning that we wanted to include an outcome when there was at least 70% consensus in all of the stakeholder groups, which was the case for 35 of the outcomes that were included in this preliminary list prior to the Delphi. And as Kelly already described, we really wanted to make sure that that the patients are really heard, that we found the patient voice the most important. So we also wanted to consider outcomes that were deemed important by patients, but not as much in the other stakeholder groups. So we also decided to include outcomes when there was agreement in patients and at least 60% also in any other group. And just to mention that we also created an additional nice to have set, which could be implemented when resources are available in the hospitals, which includes outcomes that were deemed important by patients, but not by the other stakeholder groups. This is an overview of the case mix variables included in the final core outcome set, so not in the optional set. This is just a core outcome set, and it was categorized into the patient-related, diagnostic, and treatment-related variables. As you can see, all the items that were also included in the 2016 set of ICHOM are shown with an asterisk. Patient-related outcomes were related to sociodemographics, diagnostic variables related to the diagnosis, also lung function, PD-L1 expression, for example, next generation sequencing, which was really different from ICHOM because we decided to include next generation sequencing to allow to assess a large number of mutations in a short amount of time at pretty low cost, which we found really feasible in H2O. So we did not include all these separate mutations like ALK or EGFR in this outcome set. And treatment-related variables, what treatments were received and at what dose. This is an overview of the health-related quality of life outcomes. And as you can see already, it's a long list, and it was also really much more extensive than the ICHOM set. So considering our patient-centered approach and that we also consider outcomes that were deemed important by patients and less important by the other stakeholder groups, we have a really nice overview and nice list of self-reported symptoms and quality of life outcomes. And then finally, this is an overview of the clinical outcomes included in the core outcome sets. Also some overlap with the ICHOM lung cancer set, but also some additional more in-depth variables like medication adherence, treatment discontinuation due to side effects, and tumor response. And this is an overview of the timings we proposed, the frequency of measures. We mainly adapted the figure from the ICHOM sets published in 2016. Similarly, we want to collect the PROMs at baseline 3 months, 6 months, 1 year, and then annually. However, we also want to collect the treatment-related case mix variables at 6 months and then repeatedly when there is a recurrence or progression, and clinical outcomes like survival, for example, could be measured after 1 year and then annually. All right, so this was a really brief overview, and now I would like to give the word back to Francesco and open our panel discussion. Thank you.
Kelly, thanks. Great, very short description where we are. And now I would like actually to start the discussion with Helen and Matthias with one question. I mean, basically, you've been part of the core outcomes definition. What is your first take at that, and how we should actually consider the results of this in moving to the next stage, that is basically the definition of prompts, or that are going to be considered basically for H2O to be part of the app, that or part of whatever basically system will use basically to be presented to the patient to measure basically their status over time. So Matthias, you want to start? And
yeah, so thank you. I'm very happy to be part of this project and also of this panel discussion. Thank you for this opportunity. So overall, I think that has become, again, very clear in these very nice presentations that the collection of prompts is very, very important and provides a lot of information that is oftentimes not captured adequately by the patient, and then also not by the treating team, of course, and items and issues may come up that would otherwise not be very open and would never affect how the patient is even treated or managed or handled, and how the conversations go. I think looking forward, and we started discussing this in one of our last group meetings, is the problem of how to implement what we are collecting, right? So once we have defined the core outcome sets, once we have defined how we collect those and how these are presented to the physician or the treating team, how do you implement those? Because in the end, this will be a lot of information, new information that may also lead to challenges in terms of introducing new information that needs to be somehow digested, that needs to be reacted to. Somebody has to look at that, has to read it, discuss it, and find out what is really important or what is information that can be used at this specific point in time. We have to keep in mind that there's a resource problem also on medical side. All of our medical or healthcare systems are very strained, not only now, but even before the pandemic. There's very little time per patient that you can spend. So there will be not so much time to discuss all the aspects that come up. And for some informations that are captured by questionnaires, like those described here, the physician or the oncologist may not even be the right person to speak to, right? I cannot give much qualified advice on relationship issues, for example, as an oncologist, or on worries about financial situations or so. And then there might be symptoms that might be better discussed with a cancer nurse or with a dermatologist or so. So I think what we need to define in the next step is which item may lead to which reaction and how to implement it efficiently in the clinical workflow, so that on the one hand the patient has a benefit, and on the other hand also we can make sure that the physician or treating team has the capacity to react adequately to it.
Thanks. That's introduce also another concept of the multidisciplinary approach of the patient, and basically seeing the patients in a more holistic way. And I think it's, I mean, if we basically take into consideration always the measure outcomes that truly matter to patients, as we have basically done over the last 2 days. Helen, what is your take? Also, in this respect, there is a question in the chat that is basically ask, are you going to propose more, you're moving more into the validated questionnaire in spite of the length, or you will develop you privilege basically more newer questionnaires that are probably shorter to the point, but maybe not fully validated. How would you?
How to validate? I mean, this needs to be, of course, validated to see how the response is, and exactly was as Matthias mentioned, how it will be implemented, how is it going to be used in everyday clinic. So of course, this needs to be validated. And in that validation, we need to also have a specific endpoints about this, the logistic part. What does the oncologist do with this information, and what does the nurse do, and etc. We have the social workers who can handle some of these questions. But I believe that it depends, because there are so many questions, but all these questions are not necessarily needed to be answered at each assessment. So for every assessment, some set of these outcomes are going to be measured. And I'm thinking as a medical oncologist with breast cancer, as a subspecialty, we have so many new drugs that are coming in. And we see, for example, the CDK inhibitors, that they are having a lot of side effects, especially in the beginning, like the first 2-3 months. And then a lot of patients actually are discontinuing this treatment. Why? I think because maybe we, the medical oncologists, we are not listening to all the symptoms. So for me as an oncologist, maybe some skin rash, the adverse event is not so, I mean, if you have a good response on the tumor, then some rash, you can, I think that you could live with some rash. But for that specific patient, maybe that rash is not really, she cannot live with that. So I need to listen. And as Matthias mentioned, the time is limited when we have these visits, and maybe I am taking over because I need to tell her all about the exams, the new treatment plan, blah, blah, blah. So maybe the patient feels like that they don't want to interrupt, or they don't take it up as a point. And maybe they just call a nurse after 2-3 weeks, and then they say, I want to discontinue my treatment. And that's so sad. A treatment that maybe has a good effect.
So what you suggest as well here, that is basically has potential implication of that the development of the PRO as a standardized language also to communicate, may be used basically also to communicate in a faster and more effective way what really is important for the patients, but for that specific patients, basically when it comes to a consultation. So ultimately, rather than, I mean, one can think that rather than considering basically a negative factor on time, this can be a factor that is positive, because streamline basically conversation and streamline basically the communication, what is bothering patients, what is critical in terms of adverse event. Bella and Kelly, what is your next step? What is the plan for this? And I think with that we have to close because it's 5. So we have 1 minute for the next step.
Yeah, shall I go first? So I think this is just a really great. This has been a really great discussion now about the next steps for implementation. Also, I think we are currently really working towards the first ethical approvals, the discussions with healthcare providers. We also want to involve all the patients, the patient advisory board, and make sure that we really have all the important people together to make sure that we develop the right materials and make sure that we can really implement the sets in a way that is feasible in all the several centers. So I think it's also really important to consider that there are so many differences between the countries, between the disease areas. So the different disease areas want to implement in the same center. So there's really a lot of a lot of things that we are currently trying to achieve, and yeah, we are working on it. So that is just a really short answer regarding this. And at the same time, we're now trying to get the 2 manuscripts on these core outcome sets published. So that is really a nice output for the efforts we have conducted in the past year.
The spoiler alert, there will be in the manuscript, will be also the next step and how you're going to translate that in the core outcome set into the PRO, the set of PRO measure that you're going to include in the
the selection of PRO of prompts, you mean? Yes, definitely. So we have selected the prompts, and we mostly found that the ERTC measures were mostly feasible for the H2O project, as they are really efficient in addressing all the outcomes of the outcomes sets we have defined. So
Yes.
we will move forward with those. Yes.
Kelly, anything to add as a closing? We have 1 minute grace.
Just a short note that this, of course, has been quite a theoretical exercise, I think. And for metastatic breast cancer, we are currently pilot testing this, or going to pilot test this in several hospitals in the Netherlands, just to see if it's actually working in practice, what we came up with in theory.
Very good. Matthias and Helen, any final word on well, in general about the project? I think what will be for you the H2O success in the oncology area, because I think that's basically clearly an area where we are particularly involved.
For me, like any good research project, we find some answers and some ideas, but we come up with more and more questions as we go along. So how to implement, and there's also a question in the chat, whether it's sufficient to measure PROs every 3 months. I think thinking about the future, at some point, we will hopefully reach the point where we have some digital devices or so that can measure these more continuously. But again, then we will have new questions. How do we collect and interpret all this data and so on? But it's a very interesting project, I think, and very, very relevant for the interaction between physicians, not only physicians, I mean the interdisciplinary treatment team and our patients.
Well, I agree with Matthias, the same, likewise, that I mean, for us, this is important. I think it will make our workflow more efficient, and the patients will also be able to tell us what is actually bothering them. So more open communication through this.
That's really a nice way to close basically the H2O open house. We are 3 minutes past the hour. So really what we have heard for the 2 days, measure outcomes that truly matters to patients, measure in a standardized way, measure in a way that are basically easy to basically use from the patient. And as well, something that came up yesterday, move away from data protectionism and move more in the direction of data protection. So data should be protected, but then they should not be basically at any cost maintaining a silo where actually the people that really need to see the data, being healthcare professionals, being basically people that take decision about health, being particularly patients, basically don't have access to them. So with this, I would like to close the session, and thanks everybody. Has been great, and it's been great working with you, and it's great also talking to you today. Thanks.